I would like to welcome everyone to today's webinar. It is 5 o'clock in Europe, 11 o'clock on the East Coast of the US. We have started on time. Today's webinar is entitled Syngeneic Mouse Model Ready for Immunomodulatory Drug Testing. And this is being presented by Mr. Jean-François Mirjolet. To start, I would like to introduce myself. My name is Christa Vitrui, and I will be your host for this webinar. First, I would like to address a few practical matters. They will be available to all attendees. We will email you a link to this presentation by email. The rest of the presentation, our presenter, Dr. Mirjolet, will answer a few of your questions. So if you do have any, please type them in the control panel that you see on your screen. Other attendees won't be able to see your questions if you send them directly to François or to myself. If you see the control panel, just click on the top arrow on the top of your screen. In case there are questions that cannot be answered by the end of today's session, François will respond to you by email. If you are experiencing any technical difficulties, please send a message to the host and we'll be able to assist you. I hope that you enjoyed today's presentation. Now let me introduce you to Dr. Jean-François Mirjolet, our speaker today. François is the Technology Director at Oncodesign. He's been working for Oncodesign for over 11 years. And by arrival at Oncodesign, he has played a central role in development of reconstituted immune system in mice. Jean-François obtained his PhD from the University of Nancy in France in cellular pharmacology of anti-cancer drugs, followed by a postdoctoral position in the University of Brussels in Belgium in chemokines and chemokine receptors implication in cancer cell migration. He's Technology Director at Oncodesign, directly supporting our business development activity and working closely with our clients to select the most appropriate study design for the evaluation of their therapies through clinical studies. Said that, let's begin the presentation. Jean-François will guide you through the slides that he will show you today. Okay, Jean-François, are you ready to start?
Yeah, I'm ready. Thanks, Christa. So, hello everybody. So I will talk today about Syngeneic model and their use in testing immunomodulatory compound. Presentation will be split in various parts. So starting with short introduction, then talking about the Syngeneic platform here at Oncodesign, addressing few technical questions in order to how to use this model, and then presenting case study, so dealing with results and using this Syngeneic model. First, to start, from now about 10-15 years, there is a lot of efforts in using compounds that interact or help immune system to kill or find tumor cells. There is therapies that mainly composed of tumor targeting antibody, but also transfer of fully functional immune cells like adoptive cell transfer, and there is now compound that target not only the tumor cells, but that target immune cells by itself, and in order to help immune cells or restore immune function against the tumor. In addition to that, all the old therapies that has been developed against cancer has now been thought to be able to modulate immune compound and function. And from them, we see that quite all compound has the potential to interact or help immune cells to fight cancer. And the way to have that is the compound needs to induce an immunogenic cell death. And it is now well demonstrated that part of this compound you have blamicine, bortezomib, or drugs like doxorubicin, oxaliplatin, and other kind of therapies like photodynamic therapy or radiation therapy. So we have to take into account in our evaluation of compounds that target tumor that they also can interact or modulate immune function. In order to detail a little bit what are the interactions between cancer cells and immune cells, there is a really nice paper from Chen and Melmat that deal with that, starting with explaining the cancer immunity cycle. So, with initiation of the immune response that starts with release of antigen from the tumor cells, then the capture of this antigen by antigen-presenting cells, then priming of T cells and trafficking of T cells toward tumor in order to recognize tumor cells and then kill them. There is now a lot of compound that is already interacting with this cancer immunity cycle, and you have that is so to increase release of cancer cells antigen, like chemotherapy, radiation therapy. There is vaccines that is increasing the capture or the priming ability of disease. There is compound like CTLA-4 targeting antibody that interact with priming of T cells, and there is also compound like PD-1, PD-L1 targeting antibody that really help the effect function of immune cells. And you have in all of these therapies the transfer of fully functional T cells like CAR T cells that interact really at the end. So replacing the existing immune function by new one at the early end of this immunity cancer cycle. Now is the question to what is the best model to test compound that work with immune cells and having the way to not only evaluate the capacity regarding immune function but also addressing the therapeutic efficacy of this compound. So we need a model where we have both immune cells and tumor cells. So there is a recent paper from Varsa and al. That describe all the oncology model available, starting from xenograft through PDX model, Syngeneic platform, and at the really top you have humanized mouse model. So there is not too much option to test immuno-oncology related drugs. In fact, you have only that kind of model, starting at the bottom by Syngeneic model and at the top with humanized mouse model. As for this compound, you need two more and immune systems that are able to crosstalk to each other. The topic of today is really to focus on Syngeneic model and try to define the best way to use them. The advantages of this Syngeneic model is first, they are really old. We know them and we use them for more than 30, 40 years. This is one of the advantages. There is few things to take into account. We have surrogate compound that targets mouse systems, so mouse immune cells, mouse tumor cells. So your compound has to be a surrogate unless you have to create the gem model that express either human target on mouse immune cells or mouse tumor cells. There is also few drawbacks. The tumor tend to grow really fast as compared to what we have in human, and that limits the window of treatment and the ability to see efficacy of the compound. So to deal with that. But there is a lot of advantages. It's relatively low-cost system, it's reproducible, and we have a long history of use. So there is now the time to move forward with the Syngeneic model we have here at Oncodesign. So we have established a lot of models, and here a summary table of what we have available or ongoing to be developed. So in this model you can find the name of the model, the way we have developed it, meaning the site of injection, autotopic model, IV disseminated model, regular subcut model, and some kind of compound we have tested on this model, and if we are able to follow up metastatic dissemination in addition to primary tumor. We'll not go through that list, but it could be helpful for you to go better and find if there is something to help your drug development. We'll now address few technical questions. In fact, these all, as I said, come from the past, and we have a lot of information using them, but in the equation of hot chemotherapy. So for that, we don't need really the immune cells. We just need a tumor that grows and then address the efficacy of the compound. Use model for testing immune-related function. So we need few refining, few adjustments of the way we have used it in the past. First, the limitation regarding the strain. There is a Syngeneic model available for mouse rats. For the rat case, there is a lot of limitation regarding the readouts, meaning in the mouse system you have a lot of tools onto the ELISPOT assays, system to address immune response. That's not the case in rats. For that, mouse system has a lot of advantages as compared to the rat. As I said, you're adding the therapeutic option. You have to work with surrogate compound, so that cross either react or react with mouse immune cells and are able to recruit mouse immune cells. Also questions regarding the clone. For testing compound like CTLA-4 PD-1 targeting antibody, there is questions regarding the type of clone, and regards the type of antibody. Is it from rabbits, rats? Is it IgG1? So all that small details has to be taken into account when talking about mechanism of action. And regarding the efficacy, the study itself, Most of the time, when we address efficacy of chemotherapy, we start working with established tumor, and sometimes with really big tumor volume to start with. We are thinking differently when using this model for testing immune rate function. We have to consider starting not early to avoid no take regarding the tumor, but not too late as we have to still be be able to break the tolerance. Instead, the immune system will be already established, and there is no way to reverse its function. So, what kind of efficacy readouts are available? So, as usual, we have tumor growth. So, the tumor volume, the METS dissemination is the common readout we have in preclinical evaluation of anti-tumor therapy. But in this Syngeneic platform dealing with immune system, we can also address the ability of immune system to keep worry. So we have to rate efficacy of compound using primary response, but also after a second challenge with tumor cells, the ability to observe regrowth or memory effects. In addition to that, we are working with compounds that interact with immune cells. We just want to know if we have change in this immune phenotype. So we can take blood to address change in blood number, change in phenotype, but we can also address really mechanism of action within the tumor. So we can collect the tumor by itself and address change in infiltrates or phenotype of those infiltrating cells. Regarding the readouts, we also have to take into account the presentation of the data. Most of them, what we are presenting is mean curve, median curve. I will show you that for those kind of compound, we have to work with individual curves and counting what is the good responder, the median or partial responder, and the non-responder, and working with mean and median representation. It's now the time to present few case studies. So using those kind of models, those kind of readouts to address function efficacy of immune compound. So the first model is 41. So it is a well-known breast carcinoma model, Syngeneic, so growing on BALB/C strain of mice. You have here what a regular way to present results. So it's mean tumor volume and growth curves, and here T value, meaning T versus control, and CTLA-4 targeting antibody, PD-1, so CTLA-4 in red, PD-1 in green. So you saw that results, you can conclude that CTLA-4 PD has a really moderate efficacy against 41 model. But as I said, you have to consider growth and individual growth. So this is the growth of the 10 individuals in the control group. Same thing for the CTLA-4 treated arms. You can see here that we have some individuals where we observe growth of the tumor and quite the same way as compared to the control. but we observe 3 that seem to be good responder. For PD-1, again, we can not evidence efficacy of PD-1 targeting antibody using 41 model. The advantages of 41 model is we can address growth of mets in parallel of the primary tumor growth. And this what you have here. So we have lung mets, and you can see here in the blue groups that correspond to control, we have about 41 lung mets. In CTLA-4 treated, you have about 36, and a little bit less in PD-1. It's really interesting when talking about individuals is for the 3 good responder here, there's no mets at all. So in primary and in the mets, you can evidence few good responder. That is not visible when talking or presenting mean median value data. A model of interest is CT26, which a same model of colon carcinoma. And you have here the individual response. 10 were in the control, good response in the CT4 arm, and something really heterogeneous in the PD-1 groups. What is of interest here is we have tried to evidence change in immune infiltrate regarding efficacy of CTLA-4. So we have collected spleen, tumor lymph node, and tumor by itself, and have this sample analyzed using flow cytometry to understand change in Tregs, CD8, T effector cells numbers. So these are the results of the percentage of Tregs within the tumor. So in the control group, you have about 9% of CD4 that are Tregs. Treatment with CTLA-4 targeting antibody, we have a decrease in the Tregs percentage. So from about, we are now about 5%, and in PD-1 there is no big change. So it is a good marker of response. We observe tumor efficacy, we observe change in Tregs percentage. In addition to that, we are able to address the T effector Treg ratio, meaning we not only want to see a drop in Tregs, so that CTLA-4 targeting antibody is aimed at depleting the Tregs, we want to see an increase in this T effector Treg ratio. We want to have T effector function, so we want to have this picture evidence. This is what you have here in the graph. So this is T effector Treg ratio within the tumor, so about 4 in the control group, and for all 10 individuals we see an increase, and the mean values is now 8 in the CT4 treated group, and no big change as for the PD-1 treated group. So we have here the primary response, meaning at the end of the treatment, we do see efficacy, so through a decrease in tumor volume. We do see a change in immune infiltrate. I've said that we can show memory effect, and this is what we've done using this CT26 model. We've done using a combo study, so assessing efficacy of the combination of both PD-1 and CTLA-4 targeting antibody. So again, you have here the individual growth curve, so for the control, for PD-1 arm, showing only 2 response, the CTLA-4 arm with our 100% response, and the combo groups, where we do see 100% response. So if we stop the study right now, we are not able to say that CO is better than CTLA-4 alone. However, if we continue to monitor the growth, we see that there is 3 relapses in the CTLA-4 group, only 2 in the PD-1 combined to CTLA-4. That's a big change. With even more. So we have decided to re-challenge the responder in both CTLA-4 alone and PD-1 combined to CTLA-4. And this is what here. So we challenged 5 animals, and we have 2 growths in this CTLA-4 treated group. And for combo, what we observe is no growth at all. So stop the study at the primary endpoint, meaning just primary efficacy. There is no differences between CTLA-4 alone and PD-1 combined to CTLA-4, to increase the follow-up and re-challenge animals, you can evidence really nice differences. 8 complete response instead of 7, and no regrowth instead of 2 out of 5. So this is the way to address memory response in those kind of models. Another interesting case is EMT6 tumor, and you have here again the individual growth curve, where we see heterogeneous response in CTLA-4 treated group. So 7 response, 3 non-responder at all. Again, we have collected the tumor at the end, and we have an infiltrate. What you see in the tumor draining lymph node is percentage Tregs of about 11 in the control group, a decrease in the CTLA-4 treated group, no change in the PD-1. However, we have 2 populations in the CTLA-4 group, and we have highlight those 2 populations. So the 3 open symbols here are the non-responder, and if we take these 3 non-responder out of the median calculation, you can see that starting from 11, we are now at 9% of Tregs. So we increase the differences between those 2 groups. In addition to that, we have performed the same thing in the tumor. The picture is meaning about 30% of Tregs within the tumor, and a decrease down to 5 in the CTLA-4 treated group. Again, the 3 non-responders are the one where this Treg percentage remains always upper than median value. I have here a summary graph showing this result where we do have tested both CTLA-4 PD-1 and where we have T effector Treg ratio data at the end of the treatment, and we can see few things. We have change in background level in the control group, a ratio of about 1 in both CTLA-4 EMT6 and a ratio of about 4 in CT26. And CT26 is for the best responder for targeting therapies. Treatment 41, quite no efficacy, no change in this ratio. CT26, 100% efficacy and a really large increase in T effector Treg ratio. And EMT6, we do have an increase, and we are able to evidence the responder that remains close to the untreated group. We do have also orthotopic model in this Syngeneic platform, and for all of them we are applying MRI to be able to follow up the growth instead of having only survival data. So you hear the result of an Hepatocarcinoma model, which is called ELISPOT model. You have here the positive control for this model, and this is sorafenib treatment group. You have 2 options to analyze the results. Either do stomach sacrifice and have liver weight. And you can see here that in the control group, the liver is about 3 grams, and after treatment with sorafenib, it remains close to 1 gram, which is quite the normal value. Here, one example of the MRI images, where you can easily define the tumor area. So you have here information regarding the structure. So in red you have the liver, the blood aorta, you have the stomach in green, the spine cord in yellow, gallbladder in pink, and here in purple you have the disseminated tumor. So here, and a small dot here. We have also for this model a circulating biomarker, which is alpha-fetoprotein, and we are able to correlate the secretion of alpha-fetoprotein with the tumor growth and the response. So you here a serum alpha-fetoprotein level in control group and a significant decrease in sorafenib treated group. And here the correlation between the serum AP level and the liver weight at the end of the study. We start to data on immune checkpoint modulator using those kind of orthotopic model. And for IPA16, we have found that we have a really nice responder testing CTLA-4 targeting antibody. So the liver weight here at the end of the study is again close to 3 grams in the control group, and there is quite no change at all as compared to a healthy animal, so a liver weight of about 1 gram in CTLA-4 treated group. Another example of autotopic model is a bladder carcinoma. So here the tumor is growing inside the bladder. You have here the survival curve, quite no efficacy as for the mitomycin C treatment group. I can see here that when addressing the tumor volume using MRI, you can see efficacy of mitomycin. So again, the survival follow-up is not the best way to address efficacy of compound. Addressing tumor volume using MRI really help us to evaluate efficacy of compound. Things you have here, so imaging of the bladder using MRI, and you have here in blue the bladder, and in yellow within the bladder the tumor by itself. And again, started to collect data on immune checkpoint modulators. So these are the results of a PD-1 study. Show that we can increase the survival of MBT-2 tumor-bearing animals when they are treating with PD-1 targeting antibody. So we have an increase in survival, and at the end, 40% of tumor-free long-term survival. And I have an additional orthotopic model, which is the Renca kidney carcinoma model. You have here survival data showing increase in survival after sorafenib. This model is interesting as, again, we have growth of in parallel of growth of the primary tumor. So here the response of the lung and response of the tumor after gemcitabine treatments, showing efficacy at both sides. And we also have applied MRI in that case. And this is another advantages of MRI for Renca models. And I will explain you why. These are MRI images from tumor-bearing animals. So you have primary tumor here in kidney. Here, the lung. This is data from D9, so 9 days after tumor implantation. These are the results of day 14, where you can see the growth of the primary tumor and also the infiltration of met within the lung. And here, follow-up images of 3 animals, then day 14, day 18. And what we can see here is in day 18 is the lung is really full of mets. By just looking at the behavior, the health status of these animals, there is no external sign of disease. There is no issue with breast function, but if you see detailed MRI picture, you have the right time to terminate the study, unless you will have deaths of these animals within the next days. So you want to collect data on animals, you have to terminate the study around day 19. So after having showing all these studies, it is time to conclude. So as a conclusion, I have summarized checkpoint inhibitor data on this Syngeneic platform. So we have collected a lot of data using CTLA-4, PD-1, PD-L1 targeting antibodies. There is all that comes now, like GI4, like 4-1BB targeting antibody. There is also combination data available. You here the type of response. So red is 100% non-response. Once orange, it's moderate partial heterogeneous response, and when it's green, it's the 100% response. A lot of ongoing studies where data should be available in the next coming weeks. We have also added to this in vivo platform a lot of readouts regarding immunological function. So we are able to quantify cytokine within the tumor, within the plasma samples. We are able to phenotype and quantify immune infiltrates or immune circulating cells through flow cytometry, through immunohistochemistry. So histochemistry has an added value towards data. It helps to have a structural representation of the tumor, so having the ability to localize the infiltrate, as it is now well described that tumor cells are able to block, to decrease the infiltration of the immune cells, and PD-L1 is one of the mediator of this inhibition. So we can evidence PD-L1 localization at the periphery of the tumor. And we also have a lot of tools to evidence functionality of the immune cells. So cytotoxic activity, function ability, specific T cells using ELISPOT, or also performing cloning forming unit assays, so to discriminate the whole picture of immune cells. So I to have evidence the interest of still working with this Syngeneic mouse model. As a conclusion, I want to mention that we are working with humanized mouse model for more than 6 years, and we start to evidence proof of concept study on this humanized mouse model. So humanized for the immune system, but also tumor-bearing system, so ability to have a crosstalk between human immune cells and human tumor cells. And to finish the talk, I would like to mention that we will attend the next EACR NCI ORTC meeting in Boston in November. I will be part of the Oncodesign team that joined this event, so if you want to have an appointment with us, just feel free to contact me and we will see you there. So thank you for your attention, and I will take and answer some questions.
Okay, Jean-François, thank you very much for this presentation on the Syngeneic models. I hope that today's audience appreciate the webinar. And Jean-François, I have a couple of questions that were asked during the presentation. Let's read this first question. Someone asked, was randomization based on certain size of tumor at a certain day, or randomized mice on a certain day and started treatment? Want me to repeat this one?
No, I'm fine. Thank you.
Okay.
So all the data that is included in this presentation is regarding study where animals were randomized on tumor volume. It's to be smaller tumor, but still established tumor. So the starting volume is around 80 to 120 millimeter cubes. This is the results shown here. So it corresponds most of the time to a certain day to start with, but it's randomization on tumor volume still.
Okay, François, for this answer. There is one other question, actually. This is the following one. On CT26 were implanted. In CT26, randomization and treatment start on day 7. Can tumor grow slower with fewer CT26 implantation and treatment later to give more time for mouse immune system to respond to tumor and immunotherapy better?
Okay. So yes, what we've done is for quite all the model we've performed a calibration of the model. So starting with a dose range of cells, different cell density. We have to keep in mind is by decreasing the cell number, you also increase the risk of having no take, so no growth of the tumor. So the model we have is calibrating with the lowest cell density as possible. On the model, so I don't have all the picture in the top of my head, but for 41 type of model, we have two setups, one starting with 10,000 tumor and another one with 100,000. For quite all the subcut model, it's between 100,000 and 1 million. So depending on the model, we have the picture.
Jean-François, before getting to the last question, I would like to apologize to anyone whose question could not be answered today. There was quite a few technical questions, but we will get back to you by email. Jean-François, so there is the one last question we have time for. Someone asked, data presented with the CT26 model, do you have the same result with C26? Opinion, CT26 and C26 behave the same way? According to literature, CT26 is a subclone of C26. Do you need me to repeat?
No, I'm fine, thank you.
Okay.
This is a really good question. So, yeah, I agree. According to the literature, CT26 is a clone. We have not yet performed head-to-head comparison of all of this type of clone. We do have a few of them. The results may be different. In fact, you have to keep in mind that when working with a model, that is something specific, and there's difficulty to translate results obtained in side to other side if the model is different. There is, for kind of model, importance in antigen expression, as this is the way immune cells interact with tumor cells. So having the same model, the same way to do it, to grow it, is really key factor when trying to reproduce or having data from different sites.
Maybe one very last question before we run out of time. Someone asked, have you assessed the macrophage infiltrate in your tumor model? And do you have capabilities to look at these pre- and post-treatment?
So we do have now a lot of data regarding tumor-associated macrophages, so M1, M2 phenotype. We do have data regarding MDSCs, monocyte-derived or granulocyte-derived MDSCs. So we do have plenty of figures regarding those immune-infiltrated cells and within this tumor model. We do have also the capability and data regarding effector function, meaning CD8 that have granzyme pairing expression, T-alpha expression. And I don't recall the second part of the question. Could you repeat, Krista, please?
Yes, let me go back to it. All right. So, have you assessed the macrophage infiltration in your tumor, and do you have capabilities to look at these pre- and post-treatment?
We do. We have set up our assays to be able to work on small samples. So we are able to collect the lymph node, and on the lymph node we are able to perform 1 or 2 panels of flow markers. For the tumor, we have to be careful about the size of the tumor, but 100 to 200 millimeter cube, it's large enough to perform flow cytometry analysis. So yeah, we can perform kinetic follow-up.
Thank you very much, Jean-François, for the great presentation. There was a lot of requests for your slide deck, so we'll make sure that every one of our attendees receives a copy of the presentation. I would like to thank everybody for attending this webinar today, and I wish you all an excellent day.